Hi everyone, I'm Catherine McKernan from Homelessness New South Wales. Thank you so much for joining our webinar today. Before we get started, I'd just like to acknowledge that we're all on different lands of Aboriginal people from around New South Wales, so I'd just like to pay my respects to past, present and future elders. I'd also really like to acknowledge that this webinar is a production that's been organised by not only Homelessness New South Wales, but also Domestic Violence New South Wales and Y Foundations. And I would like to just, express my support for the work that they've been doing alongside me during this period. We think we've got around 350 people joining the webinar today, so I'd also just really like to acknowledge that people have taken time out from what is an incredibly busy and stressful period. And so I just really wanted to take the moment to acknowledge the huge commitment the sector's put in terms of responding to the issues, coming up with innovative solutions and practical solutions, and always putting clients first. So I'd just like to thank you for all the work that you've been doing over the past couple of weeks on this. Now for some housekeeping. The webinar will be recorded and shared on our website as soon as possible. There is no opportunity for Q&A because of the number of people on the webinar, but if you have any questions throughout the webinar, please email sectorsupport@homelessnessnsw.org.au. And what we are going to do is provide the questions to DCJ in the main, and we will work together with them to provide a published questions and answers alongside the webinar. And you can change how the speakers appear on your screen by toggling between speaker and gallery view on the top right-hand corner of your screen. I'm going to do introductions now just to allow the flow through of presentations, so you won't hear from me until the end. Our first speaker is the Honourable Gareth Ward, the Minister for Families, Communities and Disability Services. Our second speaker is going to be Brendan Clifford of St Vincent's Health. And I've lost my notes, isn't that good? Yeah, St Vincent's Health Australia Inclusive Health Program. And following Brendan, Anne Campbell, the Executive Director of Housing and Homelessness from the Department of Communities and Justice will present. And then finally, we'll have a presentation from Jay Rebeck and Ella Newland from Rebeck Consulting, who have been commissioned to develop the guidelines. And we understand that the guidelines will be available hopefully by the end of today. Over to you, Minister.
Acknowledging the traditional owners of all the lands in which we are residing, can I also take the opportunity to thank every single one of you for the work that you're doing at this very difficult time. Thanks to the peaks that have been in constant contact. We have a phone hookup with all of our sector peaks every Monday, so that if there are questions that need to be raised, we have on that call people from the department as well as people from right across the sector. I've also invited the ASU and the PSA as well as my shadow minister to be on those calls, so that if there are questions that they have, it's important that everybody has all of the information they need, because we're all in this together, and I just want to make sure that all of you get the right supports and assistance that you need at this very challenging time. It's always the vulnerable that have to wear these situations harder than anybody else. And the work that you're doing at the moment is extraordinary. And I know, having spoken to many people across the sector, that there's enormous amounts of pressure. There's also a lot of confusion in relation to some of the advice. Look, we're trying to publish as much information as we can on the DCJ website. So if you do have questions, have a look at the website first. Health are also publishing a lot of information via health.nsw.gov.au, and I'd certainly encourage you to look at that information. But if there are questions you do have, feel free to come through to your peaks or through my office, and I'm sure many of you would know Matt Barton, who's my homelessness advisor, and we're keen to help where we can. Look, last week I was really pleased is the wrong word, because it's a shame that we're in this situation, but I was able to secure $34 million from the New South Wales government to assist in a number of things, one of which was boosting the funding we have available for temporary accommodation, funding for Start Safely and additional products there, as well as Rent Choice and Rent Choice Youth. This is, of course, a significant package to try and assist people who will be experiencing homelessness at this time, or of course at risk of homelessness. And we recognise that there's people that are going to really struggle at the moment, particularly with the loss of income and the capacity to pay rents. I mean, obviously in relation to people who have mortgages. Banks have been extended a line of liquidity through the printing of bonds, which is essentially allowing them the capacity to make 6 months deferrals. But the renters, of course, are the ones that I'm concerned about, and the risks of homelessness there, as well as the rough sleeper population that are there at the moment. And look, after some discussions with my department, what we're proposing to do in relation to inner city homelessness is to bulk buy a number of different hotel rooms across a number of different properties for up to a month at a time, and potentially longer, depending on how long this goes on. And I think you'll find that a lot of rough sleepers will take up the option, if they know they're not going back to the same old place, that if they know there's going to be a bit of stability, to take that up. So that's something that we're doing that I think will have some positive impacts. But obviously, if people do need additional flexibility, if you're finding that you're having issues with staffing, please contact your contract managers, and we're more than happy to have conversations around how we can keep services going. Service continuity at this point, having a business continuity plan is really important. And I know that there are also questions around hygiene and what to do. And look, if you can't find that information on either our website or the health website, feel free to come through to your peaks, or to come through to my office directly. Look, I think that's all I really have to say at this point, Catherine. Is there anything you'd like me else to touch on?
No, I think that's a good overview of what's going on, Minister. And I realise that you are very busy. So if you've got other, I think at that point we might move on to the next presentation, if that's all right.
Just before you do, I've just remembered two other things. Look, in relation to social housing, what I've done is I've asked the department to suspend rent increases. So as you'd know, when rents are paid, they're generally a percentage of someone's benefit, someone's transfer payment from the Commonwealth Government. What I've said is, look, this is stimulus money. It needs to go into the economy. So we're not going to be taking an increased share of someone's actual increase. We're going to be leaving that alone. So rents will be capped. In relation to rent in arrears evictions, what I've decided to do is suspend rent in arrears evictions, except what I'll be asking the department to do is seek an automatic rent deduction from somebody who may have fallen a bit behind, so that we can ensure that rent is paid, and that that money, of course, goes to other initiatives in social housing and the homelessness space. So we've made it clear that we don't want to be seeing people evicted at these times for rent in arrears. Obviously, if you've committed a criminal act or you're engaged in antisocial behaviour, they're different matters, and evictions will still proceed for people that behave in those matters. But for people that have fallen behind, I think it's important that we try and keep people as best we can in place. So we've taken those steps in relation to rent in arrears. And the way we can seek to make those happen is through what's called specific performance orders through NCAT if necessary. That's an option. Look, I'm calling on the community housing sector to obviously follow suit. They've raised some concerns just around mandating that automatic rent deduction and how that might work through Centre Pay, and we're obviously looking at that at the moment. But certainly we're hoping that the community housing providers across the state also follow what I've been able to do and what the state government's been able to institute.
Thank you very much, Minister. Yes, and that was useful additional information to provide everyone. I think that's great.
One last comment.
Yeah, that's fine.
Sorry, I'm also, as you know, Minister for Disability Services, and I know that many of you would deal with people who have a disability. Look, we're trying to secure the best possible outcomes through the NDIA. We had an emergency meeting of what's called the Disability Reform Council. This is a gathering of all the respective jurisdictional disability ministers. And what we've been able to agree to is maximum flexibility around plans, additional funding for organisations. What I've raised also is around workforce planning, also PPE. There's a national shortage of personal protective equipment. There is a stockpile. The Commonwealth is administering that, but obviously disability service providers and other organisations as well are needing that equipment for the work that they do. We're also trying to move people with disabilities out of hospitals where they've got complex care needs and into supported living, supported independent living, which is NDIS funded accommodation and indeed supported disability accommodation, which is 2 products that are offered through the NDIS. So we've got another meeting of the Disability Reform Council shortly. Obviously, the focus will rightly be on the COVID-19 response, and that's where the council will be focusing its efforts. But you know, I know that many of you would see people, particularly with psychosocial needs, and obviously making sure we have the right supports in place for those groups is important. My last message before I perhaps jump off and let other far more eminent people speak to you is, if you have people that have need, please encourage them, if they can, to contact Service New South Wales on 13 77 88. Bidfood, which has been contracted to deliver care parcels along with Woolworths, Food Bank and OzHarvest, are providing food and sustenance either to people's doors or through other means. So if you are in a position to encourage people to use that Service New South Wales line, please do so. Can I acknowledge the Peaks in particular for the work done around Bidfood? That was very much you driving that, and I'm very grateful for your suggestions in that regard. And we've obviously been able to get a good outcome there throughout this time of crisis. So there's some of the things that we're doing across my portfolio. I could talk about other areas, but I think that they're probably the most important areas. But can I just leave you with this message? Again, as I started, I'm really grateful for everything you're doing. This is a really extraordinary time. No one of my generation has lived through anything like this before, but I do know that there are some amazing things happening, some extraordinary acts of care and compassion. And I think that it shouldn't just be governments, it should be all of us that lead by example this time, by checking on neighbours, on friends, on family, to make sure they're okay, because obviously the mental health impacts of something like this is truly significant and extraordinary. And I'm just as one human to another concerned about the impacts just on our communities right across the state. And I know that we've got the best people working incredibly hard. Will we always get it right? No. Look, mistakes will be made. We don't want to make mistakes, but none of us are perfect. We're doing the best we can. And I know you all are. I know you're feeling it because you're on the front line. If there are things that you think need to change, feel free to give the feedback to your peaks, come through to my office. If you want to have a conversation with me, I've got lots of time on the road at the moment. So if you do want to drop your number, if you really want to speak to me, I'm happy to do that. But trust me when I say we are doing everything we can. We're working our absolute guts out to try and do the best that we possibly can, from the Premier through the ministers, through all your local members, and of course our government agencies, and of course our non-government providers. So from me to you, thank you for your efforts, thank you for your hard work, and thank you for all that we'll be doing together in the weeks and possibly months ahead.
Thank you very much, Minister. And it would be not doing my job if I wasn't going to mention that PPE is a really big concern for our sector as well. So I will continue to be raising that with the Minister, alongside a whole host of issues that DCJ and the Minister hear from me and my colleagues in Y Foundations and DV New South Wales on a daily basis. So thank you very much, Minister. We're now going to move to our presentation from Brendan Clifford, who's from St Vincent's Health Australia and from the Inclusive Health Program. He has very kindly put together a presentation to give us an overview of the health aspects of COVID-19 and how we work within that context. So I'll hand over to Brendan now.
My name is Brendan Clifford. So I work with St Vincent's Health Australia, which is a national organisation that has the St Vincent's Public Hospitals, the private facilities and their aged care facilities. My program has a, there we go. My program has a focus on vulnerable populations that are marginalised, so homelessness, Aboriginal health, mental health, drug and alcohol, and Aboriginal health. We have a particular interest in homelessness. If hopefully you can see the presentation up.
What we might do, Brendan, is Anne doesn't have a presentation, so we might switch to DCJ and get Anne to give her presentation, then we can come back to you. Is that all right?
Yeah, that's fine.
Okay, great. Okay, we might hand over now to Anne Campbell. She's the Executive Director of Housing and Homelessness from the Department of Communities and Justice, and she's just going to provide us with an overview of the work that the department has been doing in our space. So over to you, Anne.
Thank you, everyone. And obviously we're all still grappling with IT at the moment, but firstly, I'd like to begin by acknowledging that wherever we are in New South Wales today, we are meeting on Aboriginal land. I'd like to pay my respects to elders past, present and emerging, and extend my respect to Aboriginal people participating in this webinar today. Firstly, I'd like to thank you, Catherine, your team, and also Claire and Pam for putting this webinar together on such short notice. What I'm going to do is take you through an overview of DCJ's response to COVID-19 in housing and homelessness. As you all know, the situation regarding COVID-19 continues to progress in New South Wales. While this is impacting the broader community, people who are at risk or who are experiencing homelessness will require further support. Thank you for your work today, as this situation is affecting many people, both personally and professionally. I'd like to acknowledge the professionalism and the passion of the SHS sector, as clearly the last few weeks have been unprecedented. A few communications have been sent to you, and I will provide a brief recap on key messages to date and some updates, including an update on support available for service providers, an update on temporary accommodation and changes for DCJ housing staff, an update on the service changes register we have implemented to track any changes to service continuity, an update on community housing providers, and an update on working with children and young people. And also what work we're doing with other New South Wales government departments and also with the National Cabinet process. So the first area I'll talk about is support available to service providers. As the Minister mentioned, and I think many of you know, the government made an announcement on the 26th of March to release its second stage of its stimulus package, which was really aimed at keeping people in jobs, helping businesses and supporting our most vulnerable in the face of COVID-19. The $1 billion package includes just over $34 million in funding to prevent people from experiencing homelessness. The package will provide immediate assistance to people impacted across the state. It also includes support for people to access emergency accommodation to enable them to self-isolate, as well as rental subsidies to enable people to access or sustain private rental accommodation during this challenging time. Specifically, this funding includes 14 million, just over 14 million for emergency accommodation for up to about 3,000 people, and just over 20 million for rental subsidies to support over 1,000 people that are experiencing financial hardship event, households impacted by domestic and family violence, and young people experiencing or at risk of homelessness. We're working quickly to look at how we can roll this additional funding out to support clients impacted by COVID-19. The second area is support available to service providers. As you know, we emailed you on the 16th of March outlining some of the initial steps to support homelessness services at this time. This communication is available on the DCJ website and includes messages about prioritising essential services, which includes crisis accommodation and supports for rough sleepers, covering the costs of additional staffing, such as casual workers or overtime, and helping services to find alternate accommodation options for clients and covering the cost of temporary accommodation for people that need to self-isolate. Service providers have been advised to speak to their DCJ contract managers if there are any changes to service continuity. Following this communication, our DCJ contract managers worked with you on an audit of crisis accommodation to understand the support that is required. The audit asked providers about whether their service had self-isolation options access to personal protective equipment, access to food supplies, arrangements if staff become unwell, and whether the service had a business continuity plan. Thank you all for responding so quickly to the audit in this current time, and for your cooperation with the contract managers in relation to this. Some of the information from the audit has assisted us and the homelessness peaks, including Homelessness New South Wales, Y Foundations and DV New South Wales, to work on supply issues such as food supplies. Homelessness New South Wales are also working with some service providers to support the development of business continuity plans to address the COVID-19 situation. We have committed to supporting homelessness service providers in maintaining essential service continuity, which includes providing resources to meet costs incurred for additional staffing, or when supporting clients into temporary accommodation if accommodation cannot be sourced through these existing channels. And that particularly for younger people may also include additional support in terms of people supporting young people. Additional resources to deliver essential services are now available for you to access. If you are a provider in need of additional financial support, please get in contact with your DCJ contract manager. It will be important that you first identify non-essential services you may operate to be repurposed to support your essential service delivery. Further to this, we will be releasing some guidelines for homelessness service providers, which includes public information about COVID-19, and we're hoping to issue that later today. We will go through the guidelines in the next section of this webinar. The guidelines include general tips for minimising the risk of infection, information specific to managing accommodation services, and information for mitigation and response to positive cases of COVID-19. We will continue to work with you in collaboration with the peaks to ensure that you have the resources you need to continue essential service delivering during this difficult period. So I'm going to now just give you an update on temporary accommodation and changes for DCJ housing staff. For rough sleepers, we are in the process of securing an additional 300 pre-booked temporary accommodation rooms in the inner Sydney, southwestern Sydney district and western Sydney district to ensure we have an adequate supply to meet the expected increase in demand for temporary accommodation across the Sydney region. DCJ has also been given greater flexibility to approve extensions of temporary accommodation where the client has exceeded 28 days in a 12-month period. This extension is to be considered on a case-by-case basis, taking the client's full circumstances into account. Where a client says they need to self-quarantine, for example, for 14 days and is experiencing homelessness and meets the income and other criteria, they should be given the 14 days irrespective of how much temporary accommodation they have previously had, and this may actually be for a longer period of time. The income-related eligibility criteria still apply, although the recent additional payments, which the Minister mentioned earlier from Centrelink that related to the coronavirus pandemic, are not counted as income in the assessment for income eligibility. And that's not only for public housing, but community housing providers are also applying that same rule. I'll move on to, I mentioned earlier on about a services changes register. So a central register has been developed by us to track service changes, particularly where there are reductions or closures of SHS services in response to COVID-19. This register will provide a single source of truth and an overview of service delivery impacts and where we may need to provide you with additional support. The register will track service changes to specialist homelessness services, the inner city restoration, homelessness youth assistance program, the service support fund, youth crisis accommodation enhancements, domestic violence response enhancements, staying home leaving violence, and integrated domestic and family violence. We have a team who are working with Link to Home, the domestic violence line, and DCJ districts to receive service change notifications, to verify the information so that people out in the community are aware of where capacity may be or where there may be limitations on capacity, and updating the register. The team sends a regular snapshot to me, but more importantly, they send it to Link to Home, the DB line, the helpline, and relevant district directors and other people. If people do have questions about this register, you can certainly contact the SHS mailbox, which I think you all have the address. If not, I'll make sure that goes out with the FAQs after this webinar. So I'll just move on to community housing providers, some of whom are also specialist services. They're actively, like we all are, supporting people experiencing homelessness and working closely with their support partners. To date, particularly in those in the whole of location transfer areas, have been supporting DCJ in its assertive outreach work and street counts. Community housing providers in whole of location transfer areas are following guidance from DCJ in terms of changes to the delivery of temporary accommodation and rent choice products to better respond to the needs of clients during the pandemic, while still looking after the health and safety of their staff. Community housing providers have undertaken to work with vulnerable tenants to avoid evictions due to arrears, especially in the wake of the recent moratorium on evictions announced yesterday. The next area, which is a very important area, is children and young people. We've been working closely with our child and family colleagues in DCJ to ensure approaches and messaging across all our funded accommodation services for children and young people are aligned and as consistent as possible. Specific questions raised by the youth homelessness sector are being addressed in a frequently asked questions document. This will provide additional clarification about the delivery of accommodation services for unaccompanied children and young people, including children under 18 years of age during the COVID-19 crisis. Y Foundations have agreed to gather and provide DCJ with any new questions the sector may have. As new questions emerge that are not specifically answered by the health guidelines regarding the delivery of services to unaccompanied children and young people, we will issue additional FAQs as needed. We're also drafting a temporary accommodation policy for children under 16 years of age experiencing homelessness. This policy will provide additional guidance as to when, under what conditions, and how unaccompanied children and young people under 16 years of age may be provided with TA, and in many cases also with the support to that young person. This policy is intended to address the additional accommodation and capacity needs of the homelessness sector that may arise during this COVID-19 crisis, and is only intended as a short-term arrangement. DCJ are working to ensure that the protocol with New South Wales Police for out-of-home care residential services developed by DCJ Child and Family is extended to homelessness accommodation services for children and young people. The current protocol ensures that both New South Wales Police and DCJ funded service providers prioritise alternative responses to criminal charges where appropriate when dealing with children and young people. An amendment to this protocol will ensure that New South Wales Police and service providers are clear that this protocol also applies to DCJ funded homeless accommodation services for children and young people. In addition, DCJ Child and Family will also be meeting with New South Wales Police to propose some additional measures to support the implementation of the protocol in both out-of-home care residential services and homelessness accommodation services. The next area I'll just talk to is around our ongoing work with New South Wales, other New South Wales government departments, and with the Commonwealth. So, as you know, we are working with DPC, Treasury, Department of Customer Service, New South Wales Health, but in particular with the formal ones around support to people who are renting, given the current situation in New South Wales. As you'd appreciate, there's a need to ensure that tenants and landlords can meet obligations. We're working with other jurisdictions to deliver both short-term relief and a longer-term system to ensure that people can remain in their homes. Through the National Cabinet process, we're investigating a moratorium on eviction of non-paying of rent due to COVID-19, allowing and facilitating agreements between tenants and landlords on temporary relief, engagement with the finance sector, and providing information and advice on COVID-19, business continuity, planning, clarity regarding essential services required to be maintained. It's also worth noting that there's also a lot of work underway in the domestic and family violence space. We're working with colleagues across DCJ to advocate for additional resources in line with feedback from peaks and services. We will also, I think we've started to be undertaking an audit of staying home, leaving violence and integrated domestic and family violence services in the coming week. There is a domestic and family violence webinar tomorrow where this will be discussed further. So thank you for your ongoing collaboration during this really unprecedented time, and for continuing to support the most vulnerable members of our society. We'll continue to update you, and information will be emailed and published on the DCJ website dedicated to COVID-19 matters. I'd now like to hand over, I'm not quite sure, I might hand over to Catherine, because I'm not sure who's going next. Thank you.
Thanks so much, Anne. That was a lot of information for everyone to take in. So please reminded that we are recording this. And if you have any questions, as Anne mentioned, Pam, Claire and myself meet with DCJ every second day. So we have a log of rolling items. So if there's anything you'd like to raise with Anne or DCJ, please send that information through to Pam, Claire or I, and we will follow up for you.
Great. So hello, everyone. My name is Brendan. Thanks for that, Anne. So I'm just going to go through some of the health considerations about COVID-19 and homelessness. There's a lot of information, I know, in the DCJ guidelines. So I'm going to just focus on some really important things, because I think one of the things that's happening at the moment is a degree of information overload. So I'm just going to try and pull out the important things from my perspective as a clinician working in this space. I'd like to acknowledge the Gadigal people of the Eora Nation as the owners of the land on which I live, walk and work. And I'd like to pay my respect to their elders, past, present and emerging. This presentation has been developed from some stuff that colleagues in Western Australia have done. So Dr. Andrew Davies and Professor Lisa Wood. Andrew Davies is from Homeless Health Care in Perth, and Lisa Wood is from the University of Western Australia. They've got a good webinar on this as well, if you're very interested. I'd also like to thank the N Street Sleeping Collaborative with Nehemiah for some of their Connections Week data, and pay a special acknowledgement to Stephanie McFarlane from South East Sydney LHD, and to Rebecca Sarkis, a colleague of mine here who manages the Homeless Health Service. So I'm just going to go through a couple of things. So just what is COVID-19, how it intersects with homelessness, and then just responding to COVID-19, what are some of the things we need to be thinking about from a health perspective. Coronaviruses are a family of common viruses. COVID-19 results from a new strain of this virus which started circulating in December 2019. Like other coronaviruses, transmissions by person-to-person transmission, so when people touch each other, droplets in the air when a person infected with coronavirus coughs or sneezes. That can also contaminate surfaces, either touching or after coughing and sneezing, and sharing objects that have been in your mouth with someone, so food, cigarettes, ice pipes, those types of things. What COVID-19 is a disease that's caused by the actual virus, and it's characterized by this respiratory illness mainly. So the first thing that seems to happen is a fever, a dry cough, and then for some people that will progress into a shortness of breath that needs hospital treatment. And for some of those people, they will need support to stay breathing. So they will unable to maintain their own oxygenation to a level that is sufficient for life. So they will need to go on to a respirator or a ventilator to help them breathe. It's really important to remember that 80% of people will have really mild symptoms. So that what we're talking about is this disease that's mostly okay, but for some people that has very severe consequences. The case fatality rate is changing because of the different ways that countries do testing, and it's about 0.3 to 1%. There's lots of other stuff going around at the moment as well, and I think it's important to remember that mostly when people have symptoms of coughs and colds, at the moment it's not coronavirus, but we want to test to make sure what it is. So I think at St. Vincent's here, we've done about 3,000 COVID tests. Only 2% have been positive for COVID, and the majority have been positive. So 30% have been positive for all of the other stuff that usually goes around at this time of year. Influenza, A and B, and respiratory viruses. This slide is useful just because it kind of says that constellation of symptoms, fever, dry cough, and shortness of breath, that's what we're kind of worried about. This is a useful guide generally, but it's not a guide to an individual. Each individual with symptoms need to be assessed on their own merits. For risk factors, what London uses for their risk stratification is the influenza vaccination guidelines. In Australian vaccination guidelines, homelessness already is a high risk population group, and so they are recommended to get influenza vaccines every year. So I think it's actually more correct to talk about very high risk groups within a high risk homelessness group. And those groups would be Aboriginal and Torres Strait Islander peoples, people with respiratory disease, emphysema, asthma, those are immunocompromised, so people with cancers, uncontrolled HIVs, and those on long-term steroids, those with liver disease and other chronic conditions such as diabetes, and people that are pregnant. We have been able to start looking at the Connections Week data from last year, just to kind of get an idea of our rough sleeping and our crisis shelter accommodation cohorts, to see about how we could start rapidly rehousing them. So Connections Week data was done by the End Street Sleeping Collaborative, and it surveyed 362 people across rough sleeping and crisis shelter accommodations. About 16% of those people were scored lower than 4 on the BI-SPDAT scale, indicating that they actually don't have any health issues that we would need to be worried about at a health service system. About 50% of those people were Aboriginal. And then of the people that were greater than 4, so people that have moderate to high levels of need, psychosocial and health, 70% of them had asthma, 6% had emphysema, 2% had cancer, 9% had heart disease, and 6% had diabetes. So even within this high-risk group, we've got some very high-risk groups to consider as well. This is a good slide that just shows where the which age groups are affected the most by it. So you can see that mostly it's people that are younger and well that are getting it, but the burden of disease is much higher in people that are over 60 and 70. And we know from our whole population that actually we need to adjust for frailty, and that we should be considering over 55 as frail in this population. So when I'm thinking about COVID-19 and homelessness, I think about this triple impact. So there's an impact of COVID-19, the disease itself. So like we've just looked at, people experiencing homelessness are more vulnerable to COVID-19 because of their comorbidities, but also because of their decreased access to resources to stay well. So that includes things like food, being able to partake in physical distancing, being able to use hygiene facilities, being able to self-isolate in one's own home. There's also the impact of the response to COVID-19. So the effective measures such as physical distancing and self-isolation on mental health and substance use needs are really need to be considered in our health response, as well as the impact of COVID-19 on homelessness services provision. So reduced services and reduced staff means that people who have poor social networks to compensate for reduction in services are going to be really adversely affected in their psychosocial well-being as well as in their health. And certainly I think we're beginning to see that there's a level of anxiety that's really increased with this population. The other impact on COVID-19 is on the health system. because we're expecting this surge of COVID cases to take up most of the hospital's resources, and we will need to ramp up our intensive care services. A lot of health services, we're doing the exact same thing as homelessness services. We're seeing what's non-essential, what's essential. Mental health and drug and alcohol are essential services to keep running during a pandemic. But we need to start thinking about new ways of doing this. And a lot of what we're doing is moving to telehealth, but this obviously has some implications for people that don't have mobile phones or don't have data plans that support that. So they can end up actually reinforcing inequities in access to care. The first thing that I think is important in a situation like this is actually knowing your information. So knowing your information lines. So I think we're getting to the point now where we've got an information system set up. The two Bibles that you should be kind of looking at are New South Wales Health COVID-19 internet site and the Department of Communities and Justice. They have their coronavirus response as well. So that should be where you're going for your information. We're hopefully supplementing that from a intersectoral health alliance point of view. Stephanie McFarlane at South East Sydney has started producing, in collaboration with the health services in Sydney at LHD and St. Vincent's, a COVID-19 bulletin, a weekly one that would have gone out for the first time last Friday. The first bulletin has your local public health unit details. That's your point of contact for if you're concerned. We've also got some general advice on managing people with suspected COVID-19, and also some suggested text on how you might contact health services if you're concerned about somebody. So a script for how to contact an ambulance. There's other resources available in other languages for specialist homeless services that might be, that would have a multicultural population that they're looking after. These are two really good resources that we found useful internally. So we have our own residential facilities, and the first one is an online training, infection control training course available from the Commonwealth Department of Health. That's aimed at health workers and residential care workers. And I think we've had feedback from some specialist health services that they find it really useful. So we should be getting your staff to do that. They're based on this guideline, which is focused on aged care facilities, but a lot of the principles will be the same for congregate residential facilities. I think the guidelines from DCJ spell out in much greater detail about what to do if you're concerned that a resident has COVID-19. Just to mention here that you refer to your usual health services. So whether that's a GP or if you're in an area that has outreach homeless health services, certainly we're very happy to take phone calls from specialist homeless services that might be concerned in our area. There's a couple of other information resources that people could be useful for people. So one is around harm reduction. So people that use substances need to start planning about what might happen during greater restricted access to those substances and how to plan ahead. And as well as that, some nice culturally appropriate materials that have been developed by Sydney Metropolitan Aboriginal Alliance there. And I think New South Wales is also just about to come out with some more stuff just to support that messaging in easy to understand and nice visual formats for other population groups. There's a couple of things about infection control that I wanted to touch on. So you've got lots of guidelines. I understand the focus on PPE, and certainly it's a concern in healthcare workers as well that we don't have a lot of access to it. I think there's a strong psychological imperative for people to feel like they need to put on armor to protect them against the virus. Because there's a limited supply, we just need to be thoughtful about what situations do we need to use PPE and what situations do we not need to use PPE. Our COVID ward in the hospital, for instance, nurses don't wear masks on that ward unless they go into a patient's room. And when they do that, they put on a surgical mask. And if they're going to be doing a procedure that will generate an aerosol, so a whoosh of air that would have droplets in it, then they put on the respirator mask. I think it's really important. People think that soap it's too banal to be effective. It's actually something that kills the virus. So because you'll see on that the right-hand side of the screen, that's what the virus looks like. That outer layer is basically a fat layer. When soap gets to it, it breaks that down. So soap isn't just washing the virus off your hands, soap is killing the virus. So if you have your hand hygiene correct, I don't know, some facilities won't have lots of places to do hand hygiene, but this is something that you can do on a practical level. And it doesn't need to be liquid soap. Hard soap is also soap. If you don't have access to soap, alcohol-based hand rubs are also very effective. You need to do some safety planning around people that would have alcohol use disorders, but certainly that's something that you can give to your workers so that they can have it. And again, frequently cleaning surfaces, using a bleach solution to wipe down surfaces frequently is a really practical way of avoiding transmission within your facilities. Physical distancing is a way of avoiding that droplet transmission if somebody coughs and sneezes. So certainly in the hospital, we don't have meetings anymore unless we're able to facilitate a 1.5 meter distance between people. So it's difficult to understand this to achieve this in a congregate shelter setting, which is why we would be recommending that people reduce capacity in congregate shelters, and especially be mindful of those people that that are very high risk. But staff also need to kind of think about these guidelines, and especially congregating in no more than 2. So in a work setting, it's understandable if you need to congregate more than 2 people, but outside of work, that actually you need to be thinking about how do we facilitate breaks, for instance. It shouldn't be more than 2 people at a time. I'm going to get back to masks again, because I just want to give a little bit of information around it. That top picture about surgical masks, the point of a surgical mask is to prevent the wearer from infecting somebody else. So a surgical mask is worn during surgery so that the surgeon or the healthcare worker doesn't breathe on the patient and infect the patient. I kind of don't understand why people wear masks, surgical masks in cars. So there's lots of, so thinking about why you're wearing the PPE that you're wearing is a useful way of kind of risk mitigating the fact that we don't have access to large resources in this way. The filter masks are something that I think during the bushfires we got very au fait with. Before that, you didn't hear an awful lot about them. This in a health setting, so our Home Health Service doesn't actually have a stock of these. In a hospital scenario, this is for intensive care, and also for caring for people that are very immunocompromised. So people that have cancer, for instance, and getting chemotherapy, we want to make sure that we have sufficient stock to keep them safe. And so when you're thinking about what PPE do you need, ideally you won't be in a situation that you need to have this type of PPE in your facility. So the next thing would be about coping with stress during the COVID-19 outbreak. So there's a lot of anxiety around the place. I think it's useful, and certainly in this organization, it's useful to name it and say that there is more anxiety, or I am feeling anxiety today, or my level of anxiety is a bit higher, and share self-care techniques. So it's about normalizing it. Finding reliable sources of information that you can depend on. So hopefully New South Wales Health and DCJ will be able to do that for you. That bulletin, again, if you need us to do anything around that bulletin in terms of this information that you need, that could also be useful. The World Health Organization has some very practical advice on how to cope with stress. And also at St. Vincent's, we have a program called This Way Up, which has some modules coming online about how to manage stress and anxiety so that it doesn't become a problem. But also for people with anxiety use disorders, how they might be able to manage their, anxiety disorders, how they might be able to manage their anxiety in a way that's a telehealth way. And really usefully, it will have a module on how to skill up clinicians who aren't necessarily mental health, but how to skill them up on being able to look after people who will be exhibiting heightened anxiety. That last link on the presentation is some really practical advice that includes some good advice from managers on how to manage anxiety in their teams, and that's from the World Health Organization. The last thing I want to look at is how we might do something like a rapid rehousing during the pandemic. And so the principles that we would be suggesting as a health service about how we can protect the most vulnerable within that cohort, how we might, which should be those influenza vaccine recommendations, and then adjusting for frailty in this population. The other thing, and we would do that to reduce transmission risk for that population. So that's associated with congregate settings in particular, which also provides wider benefits to the community in terms of not having a reservoir of risk. And then the third thing about rapid rehousing during a pandemic would be about minimizing the impact on hospital systems and essential services. So reducing the need for any ED presentation and hospital admission, and that's done through effective supportive primary healthcare in the community. So we want to continue our outreach services because of things that happen outside of a COVID-19 pandemic will still be happening. People will still need to have their infections looked after. People will still need to have their antidepressant scripts filled. That still needs to keep happening. Ideally, that should always be done in the community, but we're a very hospital-centric system. So we need to start looking at our systems and how we can actually get to where people are, as opposed to waiting for them to come to us. Considerations about how we might rapid rehouse during a pandemic. Triaging is a little bit different in an emergency situation. So we flip it from, so Adelaide, I think, is one city that's had an emergency triage system where it's prioritized people that can be rehoused quickly first. And certainly that's a good way of kind of crowd control. Depending on the resources that are available in a city, that can either be done sequentially, like in Adelaide, people that were most mobile and had least need were housed first. In Sydney, we might be able to do it sequentially, so that if we've got resources available, we can actually, or in parallel rather, we can get people with high need and low need into separate pathways at the same time. The other thing would be about proactive planning. So when people get housed rapidly like that, there still needs to be very robust planning around meeting psychosocial needs and facilitating harm reduction in those accommodation environments, especially considering how vulnerable this group is to the effects of self-isolation. There are some extra clinics coming online to help screen in the community in Sydney. And that's, so we've got some mobile testing will hopefully be coming online at the end of the week through the PHN, and there will be pop-up clinics happening in central Sydney being staffed by St. Vincent's, and we will be looking to prioritise people experiencing homelessness at those clinics. Continuity of healthcare is another important thing. When people are being accommodated, they should ideally be accommodated close to where their existing services are. And we also need to think about how accommodation venues could be able to access specialist alcohol and drug and mental health services in a telehealth way. So it may be that a person hasn't got a phone that they can use, but if there's an office there that can be delegated or to be a telehealth clinic, there's stuff we can do about that there. We've got contingency business plans in place for those alcohol and drug and mental health services to keep going during the pandemic, because I think one of the things that we are hearing from this population is that they're afraid that our hospitals will get so focused on COVID that this stuff will fall off the eye line for us, and it's not. It's core business for us during a pandemic is to keep people well, whether they have COVID or whether they have something else. Stephanie McFarlane at South East Sydney LHD is a really good contact. So if you have any question, if you haven't got that bulletin, you can reach out to her to get it. If there's anything you want in that bulletin, email us through. We're hopefully going to get some advice or some text into the next bulletin about what text you need to send with a person who's in one of your services to hospital. Hospitals aren't very good at recognizing that people are experiencing homelessness at the best of times. And so we need to, so we're working on improving that internally, but there's also stuff that specialist homeless services can hopefully do to advocate for those clients as they go into the hospital system so they don't get overlooked. I'm also very happy to be contacted if you have any other questions as we go forward. That's about it. Homelessness New South Wales. If there's anything else, let me know.
Thank you so much for that presentation, Brendan. It was really, really useful to have that overview. And also, I have to commend you on your calm and thoughtful way of presenting things as well. Like, it's very reassuring to have a calm presentation at this point. Yeah, so Brendan was very open in sharing both his and Steph's contact details. We've been liaising with Brendan and Steph over the past couple of weeks as well. So, and what we've been trying to do is help that their information is very Sydney focused, which is good, but we've been sharing that information anyway. So I think that's what we'll continue to do, to share the work that Brendan and Steph have been putting together, and then you can adapt it for your areas across New South Wales. I'll also have a chat to Steph about seeing if we can get the public health information available from around the LHDs as well. Our next speakers, Jay Rebeck and Ella O'Neill, they have been working double time over the past, I think, less than a week to get the guidelines together for specialist homelessness services around COVID-19. So I'm just going to let them get set up, and then I'll hand over to them to give a presentation on the guidelines. As Anne mentioned, hopefully DCJ will be able to release these today, so you can fully see them, but it's good to get an overview of them before you get them. And as I said, we will be coordinating a question and answer process. So once you've had a chance to look at the guidelines, if you have more questions, then we can feed that through. We've also been talking to DCJ about delivering a similar kind of presentation at a district-based level too, to just get people a chance to ask more specific questions in a smaller group setting as well. So from that, I'll hand over to Ella.
Great stuff. It's actually, yeah, I'll start. Thanks so much,
Jay, and
Catherine.
then Ella, sorry.
Yeah, no, that's fantastic. And yeah, I just wanted to echo your comments about Brendan, really, and how helpful that feedback and those kind of insights were. And it's all very complementary to what we've been putting in the documentation and the guidance that's going to be issued later today. And has helpfully meant that we can give you a bit more time with Ella today because Brendan's helpfully covered a lot of the things I was going to go through. So just wanted to start by just introducing myself. So my name's Jay Rebeck, and we'd like to start by acknowledging the traditional custodians of the land that we're meeting on today across New South Wales, and paying our respects to elders past, present and emerging. And picking up on one of the points Brendan was making, really recognising that given that Aboriginal people experience homelessness at much higher rates than the mainstream population, and also given the poorer health outcomes experienced by Aboriginal people, we do see that the sector response to dealing with Aboriginal people experiencing homelessness is particularly critical to the broader efforts around supporting people experiencing homelessness in this period of COVID-19 crisis. So my role, I'm the Managing Director of Rebeck Consulting. We're an outcomes-focused consultancy. We predominantly work in healthcare. I've done a lot of work in homelessness with previously FACS, but now DCJ for the last couple of years. And so I guess we're really just, through the work we're doing in both homelessness and health, just trying to improve, increase the focus on outcomes. And really focus on saving as many lives. Bit of background, I also led the Department of Health's Olympic and Paralympic programme through the 2009 swine flu pandemic. So I've got sort of first-hand experience of working through pandemics recently. And Rebeck Consulting, we're also working with primary health networks across Australia, particularly around aged care, and actually doing training and capacity planning in aged care facilities, which, as with homelessness, we see as being a really key focus area for support as the pandemic increases. So Ella O'Neill, who she'll talk in a few moments, she's been leading out on much of this guidance that we've been developing, and she'll provide some more detailed insights in a moment. So if I just quickly summarise what we're going to run through this afternoon. So we're going to provide, I'll provide a brief overview of the guidelines, what the guidelines' purpose is, and provide some general pandemic guidance that complements the feedback and insights from Brendan earlier. And then I'll hand over to Ella, who's going to take us through what are some of the key risks in managing COVID-19 across homelessness accommodation sites, and how to mitigate those risks, what some of the issues around homelessness accommodation sites, and how we manage those issues. And then Ella's going to talk a bit about the additional considerations of mental health and substance use for that cohort, and also additional considerations for children and young people. In terms of so I'll start by just providing a bit of an overview of what these guidelines actually provide, really. So the document we've co-designed with DCJ and SHS, Specialist Homelessness Services colleagues, over the last 10 days. It really provides practical guidance to homelessness service providers that are delivering accommodation-based responses for people that are experiencing homelessness across New South Wales through the period of this COVID-19 outbreak. So the guidance we've co-developed leans on good practice across a range of national and international sources. Very big overlap with the sources that Brendan was just talking about. So we've been looking at DCJ, New South Wales Health Department of Health, World Health Organization, and many more. And you'll find at the back of the document, there's a very extensive reference list that we've provided for all of the materials that we've used to develop the document. So hopefully that's useful. Also up front, one is just recognise that this is a live document. So as you'll all be aware, the guidance is changing on a daily basis. As the COVID-19 situation is deteriorating, as is predicted in a pandemic situation, it will continue to deteriorate for a few more weeks. There will be a peak at some point, and then the situation will begin improving. So clearly, one of the sort of general bits of advice around pandemics more broadly is that through different stages of a pandemic, you need a range of different intervention strategies as a government to achieve kind of the best outcomes in terms of reduced loss of life. So it's a live document, and this guidance will be amended as the broader governmental guidance changes. So as you all know, SHS are essential services providing support and assistance to some of the most vulnerable people in our society. And your teams are the teams that are intervening early to prevent people becoming homeless, as well as that crisis response. And as the community transmissions of COVID-19 are increasing across New South Wales, it's really important that you're armed with this guidance to help you have effective strategies. And recognising this is going to involve really close coordination across government, across the NGO sector, wider community stakeholders, and making sure that public health advice is communicated as clearly as Brendan was able to do just a few moments ago, but on an ongoing basis. And I guess we need to think about this issue from a few different perspectives. We need to think about it obviously from the homelessness communities that we're actually serving and clients that we're working with, from the volunteers, from your staff as well, and making sure that we're actually thinking about the interventions from those different perspectives. And we wanted to sort of note that we recognise that people experiencing homelessness are particularly vulnerable with, they're more likely to have compromised immune systems, more likely to suffer from mental health issues. As I mentioned before, Aboriginal people are disproportionately experience homelessness. And so the impact of COVID-19 will be exacerbated. And I thought Brendan's sort of terminology of very high risk groups was sort of helpful. And also recognising that we are going into winter now as well. So that's one of the particularly challenging things we have in New South Wales and the Southern Hemisphere more broadly. So I just wanted to move on to the next slide, which is just a bit of general pandemic guidance. And I'll just talk about the things that are additive to what Brendan was saying earlier. So broadly, important to note that by pandemic, we're talking about an epidemic that's spread on a global scale. And COVID-19 is a new infectious disease that hadn't been experienced by any humans until the end of last year, which is one of the challenges that human populations, regardless of nationality, are facing. So some of the other recent pandemics have included things like SARS and MERS and swine flu back in 2009. So COVID-19 was declared a pandemic in March by the World Health Organization as the prevalence escalated. In terms of where we're at now, as of 6:30 this morning, there was 2,032 confirmed cases in New South Wales and 4,349 cases nationally. So New South Wales has just under half the confirmed cases nationally, with Sydney and particularly Sydney Airport being very much the epicentre of the COVID-19 Australian outbreak. So New South Wales is particularly affected by this. I also wanted to just sort of, one of the questions that I was particularly keen to understand about 5-6 weeks ago when this was starting to escalate is why is it the coronavirus is so problematic? And just there's 5 key things to note here. I mean, the first is that it's highly contagious. So it spreads very easily, which really makes containment efforts very challenging. So the reproductive number is between 2 and 3, which means that for every one person that's infected, if there are no controls put in place in a normal population, between that person will go on to infect a further 2 or 3 more people. So that's quite a high reproductive number. Secondly, COVID-19 has quite a challenging fatality rate. So I think the numbers Brendan was talking about were, I think, between 0.3 and 1%. So those numbers are starting to narrow in, but that's much higher than swine flu and much higher than seasonal flu. But critically, the fatality rate isn't so high as with things like SARS and MERS or Ebola, because when a virus has a very high fatality rate, it's actually not, from an evolutionary perspective, very positive for the virus, because the virus actually kills the host before the host has been able to actually infect other people. So what's challenging about COVID-19 is it sits at that level where most people are actually healthy and go on, as Brendan was talking about, but it's able to actually individuals infect a lot of other people during the period. The third key thing that's so problematic about COVID-19 is that the incubation period is long. So typically it's between 5 to 6 days, but it can be between sort of 2 and 14 days. So what we, and that's the reason that self-isolation is for 14 days, because that's the upper limit of what the incubation period is. And so that means the illness can go undetected and people can be symptomatic. They can be actually passing on the illness before they're symptomatic. And again, that's really makes it very challenging from a containment perspective. And because the symptoms are so easily confused with the flu, many cases are going untested. The fourth big challenge about coronavirus is that it's novel. The clue's in the title, novel coronavirus. And so because of that, it means that before late last year, and because it was only in animals beforehand before it crossed over into humans, there is no immunity by definition in the human population to this disease, whereas most diseases that have been circulating, there is a level of immunity. And that again makes it very challenging, and why we're seeing some quite varied immune responses across age groups. With younger people seeming to be able to respond much more quickly with their immune responses, and older people struggling, which is why older people are often dying in higher numbers. And the fifth really problematic point about COVID-19 is, as I mentioned before, we're about to go into winter. And so typically, we have the flu season in the Australian winter. So with COVID-19 combining with the flu season, that's something that's going to make it, particularly challenging for people experiencing homelessness and the health system more broadly. So in the guidance, we've got sections on how COVID-19 spreads, which is been covered by Brendan. We've also got guidance about how to stop the spread, which again mirrors the guidance that Brendan was talking about. And finally, we've talked about the symptoms of COVID-19, which again is consistent with what Brendan's talked about. So I won't go through those now, but you will see all of that information in the guidance documentation. And so in terms of the response, again, Brendan's been through that in quite a bit of detail. But again, we've talked about how to respond differently for people with mild symptoms, people with severe symptoms. And I think the key thing to note from your perspective is that you're not healthcare professionals. And so clearly where you can see that people have more severe symptoms, then you need to be phoning emergency services for that medical attention, but recognising that the majority of cases will be mild, and that for the majority of cases it will be able to be managed through other means than going into hospital. As you can see in this slide, we've also provided key links to the key DCJ supports that are provided. And also, if there's any inquiries that you have, we've got an email address here. So again, just going back to my point at the beginning of this presentation, we do see that it's going to be a live document that we develops and improves as we go through different stages of the pandemic. And so really welcome your feedback to this email address as to how we can kind of improve this guidance in the coming weeks and months. So that was the final point that I wanted to make. So I'm just going to go on to the next slide. And I'm now going to hand over to Ella. And as I said before, Ella's going to start by talking about the risk mitigations across homelessness accommodation sites. So over to you, Ella.
Thanks, Jay. Hi, everyone. My name is Ella. And so I suppose to start off, I suppose the important thing to know is that we can actually reduce the impact of COVID-19 for people experiencing homelessness by putting business continuity plans in place with risk mitigation and issue mitigation strategies, which we're going to talk through today. In terms of this business continuity plan, the first stage in that is initial actions. So this is what you might have been doing over the last number of weeks while information about the disease has still been scarce. Now we're kind of moving into that targeted action phase as we have started to find out a little bit more about the disease and can tailor measures to ensure a proportionate response. So this allows us to provide a coordinated and consistent approach for people who are experiencing homelessness by working together. Once the disease has passed, then we can start to do stand down activities, which might include stuff like transitioning activities to normal business, monitoring for a second wave of the outbreak, and also when that vaccination does come in place, making sure that there are ways that homeless people experiencing homelessness can access this vaccination. Moving on then to screening, I suppose. So this is really the first step in risk mitigation. So it's really important, I suppose, to screen all visitors of the facilities. So this includes clients, staff, and anyone else who may have a reason to be entering the premises. And I suppose to alleviate pressure on staff, it's recommended that points of entry to the facility might be limited, so that staff are only having to kind of monitor a number of entry points where they can then ask questions like, have you been in close contact with someone who's been required to self-isolate, or do you feel feverish, or have you had a new cough, shortness of breath, or a sore throat within the last 7 days? Again, ideally, this screening process would even take place over the phone, but it is acknowledged that obviously this isn't really always suitable in this situation. And then I guess when someone does kind of say yes to any of these questions, it's important at this point, I suppose, to call the public health unit, which the number is there for you, and there's more information about that in the document, and then understand how testing might work. And also at this point, the individual should self-isolate. So we'll go into that a little bit more later on. In terms of looking at so I suppose we're looking at risk mitigation across 3 major groups. So the first is service-wide mitigation strategies. So the first thing to do is really to scale down essential services, non-essential services, so that we can really prioritize time and resources on those essential services that are going to help people experiencing homelessness over the coming weeks and months. Again, if contractual obligations are impacted, inform your DCJ contract manager at this point. The next important step is to identify system partners. So this is identifying points of contact at your local health department or nearby healthcare facilities. It also might include engaging with housing providers and just having a flow of communication with these people as things ramp up and ramp down over the coming weeks and months. Following on from this again is the looking at temporary accommodation. So there's kind of two other ways we can look at this. So we could, there may be use of hotel and motel rooms. So, sorry, bear with me a moment. So yeah, so hotel and motel rooms. Again, in this instance, it's advised to contact your DCJ manager to assist with kind of a coordinated response should you be able to avail of any of these. And then again, as additional funding is being made available for temporary accommodation, which further guidance will be released on. Another way to alleviate the kind of bed numbers and open up some beds for people is see if clients actually have safe and healthy alternative accommodation to use for a defined period of time while this is at its worst. And that will just help people who really are at the highest need to have a space in the facility. What's also important is developing symptom alert processes. So this is putting processes in place across the facility so that everyone, whether it's staff, clients, volunteers, know when and how to inform management if they have a fever or respiratory symptoms. The next one that we'll look at is restricting visitors. So again, and this is up to the facility's discretion, they may want to completely lock down the facility as things get worse, but we're advising for now that just restricting visitors to a short duration, for example, under 2 hours. Again, limiting the number of visitors at any one time and making sure that the visit is done in a space that has kind of has good circulation and potentially outdoors or the client's room that they might be in. And this is again to reduce the risk of transmission. And again, with this one, obviously we would encourage that physical distancing. So between 1.5 to 2 meters. We also need to implement stringent cleaning and hygiene procedures. So this is stuff like the disinfection of high touch areas, particularly in common rooms, looking at appropriate waste disposal, which we have quite detailed guidelines about how to actually do this effectively in the guidance. In terms of cleaning in general, there's a full section on that that is going to be helpful. Obviously, because we're looking at things like food, body fluids, cutlery, upholstery and carpets, laundry, hand washing, and then just routine cleaning and equipment. As part of this as well, we need to ensure that everyone is aware of safe hand washing practices. So using soap and water for 20 seconds and advising people to do this upon entering the facility or even requiring it. It's also important, I suppose, with this to ensure that all restrooms at the facility are well stocked with soap, disposable paper towels, and even have guidance up above the sink as to how to properly wash your hands and what these steps are. We can use communication plans such as this hand washing guidance around the facility, as well as posters that will help people to identify what sort of symptoms they're experiencing. Icons are really helpful in this use as well, because it kind of in terms of literacy levels, it's transferable to all. If we've got cold clients, they should be able to identify and point to symptoms through icons. The next one we're going to look at, and the last one in this section, is in terms of meal delivery. So there's a number of things that we could do with this. We could stagger meal times to reduce crowding. We could also stagger a schedule for the use of a shared kitchen. And we could even go to providing packed lunches or moving away from self-serve to staff-provided serve, who might be wearing gloves or even masks, dependent on the availability of PPE. The next one we'll look at is that client-focused risk mitigation. So the first step is actually in rearranging bedrooms. So we want to make sure that beds are spaced at least 1.5 to 2 meters apart. And it's also recommended to lay residents or clients head to toe. We could also put dividers in place or some sort of boxes to make sure that people aren't moving between each bed. The next one is looking at staggering shower or bathroom access. So this is to reduce the amount of time that people are using the facilities the amount of people using the facilities at the same time. In terms of separation of ill and well clients, where possible, the best advice is to use one building, if you have multiple sites, to use one building for people who are required to self-isolate due to symptoms or diagnosis, and another for people who are well. Where there's not multiple sites, it's advised to look for single rooms for residents who need to self-isolate with closed doors and, if available, a separate bathroom. Where there's no single rooms, it's advised to ring the public health unit for advice on isolation options. It's also important at this point to, again, coming back to the ones that we spoke about a little bit of the service-wide risk mitigation, is just making sure that clients know the heightened sanitation measures. So in terms of using tissues, having rubbish bins available, coughing or sneezing into their elbows where they're not available, and that understanding that hand washing protocols. We need to make sure that physical distancing is employed, so cancel group activities to move these online if available, because that actually helps the social interaction piece and the maintenance of routine. We'd again discourage the congregation of clients in common areas, and potentially you could even use a schedule again for the use of these common areas. It's also important to remember to explain to clients and staff why we are isolating people from others. So this avoids stigmatizing anyone who is impacted. The next one here is looking at discouraging residents from leaving the facility. So this might include supervised smoking breaks, or even using sign-in sheets to monitor who is leaving and entering the premises. The last one here is that importance around social interaction. So it's really supporting clients to maintain contact through electronic means where possible. And we might look at considering changing organisation rules on client access to IT equipment on site around this time, and trying to provide them with a little bit more kind of technology services to keep in contact with friends and family. In terms of the staff focused mitigation strategies then, so during this time it's likely that we're going to see an increase in staff absences because they might have to stay home or care for someone at home. Again, school shutdowns might mean that they need to care for children. And looking at mitigation actions for this, we might develop flexible attendance and sick leave policies. We can extend working hours and schedule additional shifts so long as they're within award conditions. We can also identify critical job functions and cross-train current employees so that any of these mission critical activities won't be impacted by staff being on leave. And then again, just it's ensuring that ill staff and volunteers do stay at home to prevent the transference of infection. When staff are talking to residents then, we should limit their face-to-face interactions. So we can do things like using physical barriers such as a big table. We can also stagger opening times for drop-in clients to avoid congregation. We should also use technology and apps as much as possible to support communication between staff and clients. And we can plan staffing then as well in terms of minimizing the number of staff members who have face-to-face interactions with staff. So anyone who is high risk on the staff force may not then work directly with patients who may have respiratory symptoms. Also, it's important on this one to remind staff and clients to wash their hands before and after every face-to-face interaction. It's also important to reduce staff congregation. So reducing unnecessary assembly, again, employing electronic communication means for team members. And coming to onto the PPE, the personal protective equipment, which Brendan alluded to earlier, and how this is in limited supply across New South Wales. When staff members have face-to-face interaction with an ill person, obviously certain PPE is recommended. This won't always be possible, but stuff like face masks, gowns, gloves, goggles, particularly the use of gloves is good when disposing of waste or when cleaning materials. And there's also some guidance in the guidelines around actually the proper disposal of this PPE afterwards, which all comes into that staff training on infection control. And we've got a few good resources here that you can point staff towards to ensure that they understand how to perform cleaning, laundry, and pick up activities safely, as well as the proper use of gloves. If I move on to the next slide then, we're going to look at issue management in homelessness accommodation sites. So, as hospitals are going to be under significant pressure over the coming weeks and months, efforts should be made to manage client illness outside of the hospital setting. And again, it's important to note that when advised by medical staff. Again, to reiterate the point Jay made earlier, you don't have healthcare professionals on site. And so the same as for people who are self-isolating at home, if conditions get more severe, that's when you would start to engage your emergency services. So the diagram on the right of the slide really shows what that decision tree or what that flow looks like in terms of understanding where best to manage a client. So if the client presents with symptoms or has close contact with a diagnosed person, we would see if they have mild symptoms, no symptoms, or severe symptoms. In the case of severe symptoms, you'd immediately call emergency services as you need medical attention, and the client would be redirected and admitted to the hospital system. At this point, there may be, once they've finished through the hospital system and been put on the, and kind of started to recover, we would follow medical instructions for follow-up care that we might be engaged in. Where there's no symptoms or mild symptoms, get the client to self-isolate immediately and call their usual healthcare provider. So this aligns with the advice that Brendan gave earlier as well. At this point, the usual healthcare provider might give some guidance as to whether the individual should be tested for COVID-19 or whether they don't need a test at all at this point, and the symptoms may not be relevant, which means that there would be no need for the person to self-isolate in this instance, and they just should practice good physical distancing and hygiene as before. In the case of a positive test for COVID-19, we would continue to self-isolate the client. They can, for the most part, they should be able to safely self-isolate in the home or community setting where the symptoms are mild. Obviously, if the symptoms get worse or if the person deteriorates, they'll need to be admitted to hospital, which will end up in the same follow medical instructions for follow-up care after that. Where they can self-isolate in the home or community setting, there's two options here, and it really depends on whether the facility has the right accommodation available. So if there is an adequate kind of bedroom that's isolated and they can stay on their own, then they can stay in self-isolation at the facility, and where not, we might move them to alternative temporary accommodation. So where the client has been confirmed positive and is required to stay under the care of the provider, we might look to, first and foremost, we will execute procedures for presentation with symptoms. So this might be something like, obviously, isolating the individual in a previously identified space, informing the supervisor, and notifying the DCJ contract manager. Again, when the client is isolated, we need to make sure that they have a mechanism to contact staff members if they are feeling worse. We need to keep them there as much as possible and away from other people. The next one we're looking at is reducing cleaning frequency within these rooms to as needed. So this will limit staff exposure to the virus. So they should wait as long as practical after use by the ill person to clean and disinfect high-touch surfaces. As the virus remains on hard surfaces for several hours to a few days, the sooner the staff member cleans the surface, the greater the chance they have of contracting the virus. We can also provide clients in self-isolation with personal cleaning supplies, including tapers, tissues, paper towels, and TGA approved wipes. Again, we should be careful if there's anyone who is prone to substance use, that we don't provide them with anything that could be dangerous in this instance. Again, looking at making sure they have the right supplies, we might also consider providing them with extra blankets, and also when providing food, using disposable utensils, as this is the most hygienic in this instance. Again, we need to encourage that they use safe hygiene practices, such as coughing into their elbow, using tissues, and properly washing their hands. And encouraging the steps towards recovery, like encouraging them to really get some rest and sleep, and drinking fluids to prevent dehydration. We should check in on clients who are in self-isolation every few hours using a non-contact method where possible. So this might be calling the client on a mobile phone if they have one, or placing telephones in the room so that we can call them through these. We could also check in through the window or speak through the door to clients. As Brendan alluded to earlier, shortness of breath is really what should trigger concern, and this is the point that you really look to call emergency services. Again, for high-risk clients, so like those groups we spoke about earlier, if you're older or have underlying health conditions or pregnant, we should probably reach out to these people more regularly if possible at all. I'm now going to move on to the next slide, which looks at additional considerations for people who have certain mental health needs, or who might be withdrawing from alcohol or other drugs while in isolation. So in terms of mental health, the COVID-19 outbreak is likely to cause significant increases in stress and anxiety for both clients and staff alike. During crisis situations such as this pandemic, histories of trauma may trigger high-risk behaviours. The reactions to stress include health concerns, so fear about your own health and the health of loved ones, changes in sleep or eating patterns, difficulty concentrating or sleeping, the worsening of current health issues such as chronic health problems, and also the increased use of alcohol, tobacco, and other drugs. We should communicate the availability of support lines to clients and staff alike. So the National Coronavirus Helpline has been set up, and again, in the guidance, you'll find that we have these in detail, listed in detail what the numbers are to call and where there's online chats available. Also Lifeline and Beyond Blue are really good resources here, as is Head to Health, which collates the Australian digital mental health resources and is really a go-to guide that has a lot of information available in one place, and it's a government website. It also includes access to the This Way Up guidance that Brendan referred to earlier. In terms of supporting mental health strategies, or supporting clients managing their mental health and staff as well in this time, the important points to note are to stay connected. So making sure that people reach out digitally to friends and family, and maybe even other members of the facility online. We want to make sure that people get adequate amounts of exercise. And again, stick to routine, so keep regular sleeping and eating patterns. We want to make sure that no one is overwhelmed by the amount of news out there, so advise taking a break from it when it gets a little bit too much. And again, what's really important is reaching out. So this includes video conferencing alternatives for counselling or other professional help that's required at this time. In terms of staff, it's important that staff take care of their own basic needs, as this is going to be a really busy and stressful time for them. And we need to make sure that they get enough rest and respite during work as well as between shifts. While it's also important for staff to remain connected with friends and family through digital methods where they can't talk to them as much in person. From a provider perspective, we can rotate workers from high stress to lower stress functions. We can partner inexperienced workers with more experienced colleagues, and we can initiate, encourage, and monitor work breaks to ensure that our staff are taking them. If we look at substance abuse now, so the service provider should consider contingency plans for counselling. This is obviously a service that is usually done face-to-face. However, it's important to know that there are telephone counselling options available, and there's actually some good web-based support groups which people can avail of. And again, this is all linked in the guidance or in the guidelines. Again, just encouraging self-care is really important here in that support piece. In terms of nicotine treatments, we need to provide patients with access to these to help minimize smoking and vaping, which may be relied on in these extra stressful times. For drug and alcohol withdrawal, which is expected to potentially increase as clients go into self-isolation, we should make sure that staff are familiar with this of these different withdrawals. And again, we've got some really detailed guidelines in the guidance around this. We could, and also, another resource that we have pointed staff towards, it's got really, really detailed and helpful guidelines for understanding what those symptoms are for the different types of drugs. Again, we might consider assisting clients in accessing takeaway supplies of replacement drug therapies, particularly when they're in that self-isolation period. Luckily, Brendan said earlier that in terms of preparing for programs to close, they are working really hard to ensure that these will stay open, which is keeping the pressure off the hospital systems. So it's a good backup to stockpile harm reduction supplies if in line with organisation protocols. But again, this may not be necessary as programs are doing their best to stay open during these times. In terms of increased hygiene, there's specific harm reduction practices that we've advised in the guidelines that we might communicate with clients to help them to manage their addiction while avoiding contraction of COVID-19. Additional considerations we could take for people who might be dealing with substance use issues at this time is monitoring substance users closely as they're a high risk group, and trying to making sure that we understand the differences between withdrawal and COVID-19, as these can be similar. So again, it's understanding that respiratory piece around COVID-19. We can get supplies delivered for clients in self-isolation, which includes like refill prescriptions, and where possible, we might be able to work with the methadone clinics locally to get 14 days of doses and administer them day by day to make sure that there's no overdose usage or overdoses. We can also have supplies on hand to manage involuntary control, such as medication or electrolyte drinks. And we can also ensure sufficient treatment capacity is available should people look for withdrawal support or substitute prescribing. I'll now move on to our last slide, which talks about additional considerations for children and young people. So it's important to understand that people of all ages are concerned about the virus. However, for young people, they tend to experience emotions intensely when there is uncertainty. So extra measures for them is really, really important, and a close monitoring of how they're dealing mentally with what is going on in the new world, the new normal. So we can help them to understand that healthy anxiety has a purpose, and we can channel discomfort into useful actions, such as learning about and following health guidelines, for example, hand washing practices. It's important also to manage the anxiety of staff at this time, as young people can tell when adults are saying one thing and feeling another. So really making sure that staff and anxiety is in check before providing reassuring words is important. In terms of the communication of information, we can provide young people with a list of community resources they can access that give clear and transparent information. And it's also important to clarify misinformation at this time. We can also amplify positive messages to make people feel a little bit better about it, amplify positive stories and images of local people who have experienced it and have recovered. In terms of providing and encouraging distractions is really important. We check in with young people's schools about online or distance learning opportunities, as well as providing access to things like books, video games, television, exercise apps, relaxation apps, social apps, getting people to really be creative with that social interaction piece. You could set up a social media group at the facility to encourage people to keep connected even when they are in self-isolation. Again, you could set daily challenges through this group that people can do on their own, but talk about it with each other through the apps. Another thing that's important at this point is to find positive ways to express feelings, as people can, something like creative activities such as painting or drawing can really facilitate people expressing feelings such as fear or sadness. It's also important at this time to encourage teenagers to ask questions and help them to understand the situation. Through the maintenance of routine, we can help them to feel a little bit more of a sense of normality, which includes engaging with educational resources, getting normal amounts of sleep and eating well. The next one I'd talk about is encouraging compliance with government advice. So I suppose making sure that young people understand the purpose of the decisions made to reduce physical contact, as well as the risks of COVID-19 to them personally. And again, noting that the type of tactic employed might need to vary from person to person, which is at the staff member's discretion based on the type of individual they're dealing with. Another thing that's good for young people is really giving them a sense of a way to help others. So research suggests that young people feel better when they turn their attention to that support of other people. And so encourage generosity, help them to understand that by following health recommendations, they're protecting not only themselves, but also their community. And even you could providing them with tasks within safety protocols to support the strain on services in the facility. The last one I'll talk about is the contingency plans for self-isolation. So Anne mentioned earlier that there is a policy being developed to address temporary accommodation for young people. And this I guess we need to be cognizant here that if a young person is self-isolating, they must have a 24/7 carer. And if they're on their own, we need to have 2 carers with them at any one time. So there's a few implications around this that we will need to manage. It's important at this time not to forget about older youth. So if service providers do have capacity, it might be worth reaching out to some previous members of their care who might have gone on to university or to TAFE settings, which are all shutting down now. So during this crisis, helping them with and being in communication with them could make all the difference. You can check in by phone or email, just in checking in whether they have food, housing, water. And maybe even if you have the capacity, it might be good to check that they do have safe housing and that there might be some temporary displacement for them as well, and seeing how you can help them to manage. So again, this has really been just an overview of the detailed set of guidelines that we have developed in conjunction with DCJ, which are going online later today. Again, I will reference you again to the email address if you have any further questions or anything that you want clarified a little bit more upon reading the guidelines. I'd encourage you to use this so that we can make an even stronger document that will really support you to provide care to people experiencing homelessness in these unprecedented times.
Great.
And I'll pass you back to...
Yeah. Great, thanks so much, Ella. Hopefully this guidelines, I think Ella gave a really detailed overview of the guidelines, and I know that many of you are already well on your way in doing a lot of these things, but I think it's really important that DCJ provide consistent advice and guidance around what we should be doing. It just assists us all in terms of making sure that we know that we're doing the right thing and that we're on the right track in terms of responding to COVID-19. I'd just like to take this opportunity to thank all the speakers. I think it was a really useful session. And I just wanted to remind everyone that we've recorded the webinar. We're also going to share the presentations and the questions and answers on the Industry Partnership Learning and Development Framework, and we will email the link to you with all of that information over the next couple of days. In the meantime, I hope you've been scribbling down notes around any issues that you think we need to think about, anything that you think that the guidelines might need to include. And of course, hopefully DCJ will send out the guidelines to you later today or early tomorrow, and you can have a look at those and then have a think about what else we might need to consider as well. In that case, can you please email us through the sector development email address, and we can collate those questions and coordinate that with DCJ. That email address, by the way, is the email address that you got the invitation from, so you should have it in your address book, hopefully, and if not, you can check our website to get the contact details. I'd also just like to acknowledge all of you for, again, taking the time to spend in what is an incredibly busy period, and when we're all kind of doing so much work, to spend 2 hours listening to a number of presentations is a huge ask, and I'm really pleased to see that we had over 220 people stay with us through the entire 2 hours. So I just wanted to thank you all for your time. And as I said, please keep in contact with either Homelessness New South Wales, Y Foundations, or DV New South Wales around any of the issues, and we were here to support you and do the best that we can to make sure that we get through this healthy, well, and our clients get through this healthy as a healthy and well people as well.